The first session, yeah, well, there it just pops up. Yep. I want to remind everybody that that these sessions are going to be recorded and we'll be able to post them. I'm doing a talk, the very last ITC, Intern Teaching Conference of the year. It's a talk on dyspnea. Normally this would have been part of the ITC series and would have finished by now, but because we added the COVID talk this year to the ITC, then my talk sort of got bumped to the end. So I will do that, and then we'll take a break and then move into Gabby Berger and Dan Cabrera's workshop on that's entitled Code Bias, but on you know, learning and practicing how to deal with microaggressions and macroaggressions when they occur in the clinical environment, you know, clinical arena. So with that, and then the afternoon will be lots of reflection time, and I'll talk more about that later. But Javelle, is there anything you want to say before we launch in terms of you know, the Zoom meeting and what people should how they should stay on during breaks and things of that sort?
Yeah, so we're going to be using this link for the duration of the day. So when we go on breaks and lunch breaks, don't leave the meeting. You probably heard us say this before for orientation and things. When we do breakouts, we don't want you to leave Zoom. You can minimize, turn off your video, mute yourself, but just don't exit. Otherwise it clears our breakout rooms. So I'll give you another reminder closer to lunch.
Great. And then just to say it now, after the lunch break at 12:15, that's when we'll start the orientation to the afternoon sessions. So, all right, with that, I'm going to share my screen and launch into my talk here. And I'm going to, okay, cool. All right, so I was asked to talk to you guys a little bit about what to do when you're called to see someone with dyspnea, with shortness of breath. Just before I start, by the way, I won't be able to see the chat as I'm doing this talk, so if there are questions, if someone could just chime in and let me know. But all right, cool. So this topic is obviously near and dear to my heart as a lung specialist, but it's also really interesting because it involves so many different organ systems. Okay, what is happening here? Here we go. So what I want to do for you is just a brief overview. The learning goals are to talk about mechanisms of dyspnea, your bedside evaluation of a person with dyspnea, and then the emergency care for someone with dyspnea. And we'll go through some case scenarios. So dyspnea is nothing more than an abnormal or uncomfortable sensation of breathing. That's all it is. It's very subjective. And I'm sure many of you have felt dyspneic at some point where your breathing just feels uncomfortable. It's just comprised of qualitatively distinct sensations. It varies a lot in intensity from person to person, from scenario to scenario. And it's remarkable to me that all of these types of patients can present with dyspnea. A diabetic with nausea and vomiting in DKA can be dyspneic. An alcoholic man with an acute GI bleed, liver failure, someone with severe diarrhea, elderly woman with CHF, pneumonia, PE, pneumothorax, COPD, they all have the exact same symptom, shortness of breath. Actually, just to highlight this, when I was just on service in the MICU, it was in the afternoon one day, the PERT team, the pulmonary embolism response team, got activated to the emergency room because a man in his 40s or 50s came in with profound shortness of breath for several days, breathing 43 times a minute, and looking really acutely ill. And everybody thought, oh my God, this has to be a massive PE. And when working him up, his oxygenation was actually totally fine. His PCO2 was 9. His pH was 7.03. And he had a normal lactate level, actually. But it turned out two things. He was in acute renal failure with a BUN over 150 and a creatinine of 17 and a bicarb of 3. And so he had a hemoglobin of 4, a crit of 13. So he had profound dyspnea because of his anemia and because of his acidosis, and nothing was wrong with his lungs. So again, just to highlight the fact that dyspnea is a common symptom for multiple things. And why is that? Well, the respiratory system is uniquely designed to maintain homeostasis with respect to gas exchange and acid-base status, and with the least amount of work possible. So maintain homeostasis with the least amount of work possible. And any derangements in that balance or the work required to maintain that balance results in this sensation of shortness of breath. So you can imagine that there are all these important components from the brain, the spinal cord, the nerves, the muscles, chest wall, diaphragm, pleura, airways, alveoli, heart, blood vessels, blood, and all the way down to mitochondrial respiration. These are all components of the respiratory system, not just the lungs. And so any derangement in any of this can lead to dyspnea. So again, pathophysiology of dyspnea can result if you have an increased central drive, and there are diseases that will do that. There are medications that stimulate central drive. There are psychiatric, psychological reasons for increased central drive. If you have to do excess respiratory muscle work of breathing, that causes dyspnea. Poor airflow and poor lung stretch results in a sensation of dyspnea. And gas exchange and metabolic demand, like that case I just told you about, results in dyspnea. If you're hypoxemic, you may be dyspneic. You may have tissue hypoxia without hypoxemia. That can happen, and that will cause dyspnea. You may have trouble clearing your CO2, and you may have excess acid production, all of which leads to shortness of breath. And many patients have more than one mechanism. That's just that's just true. So let's start going through some cases and talking about an approach to dyspnea. So you're the night medicine intern. The nurse calls you at 2:30 to tell you that Ms. Petunia Acco, a 68-year-old woman admitted 5 days ago for community-acquired pneumonia and a mild COPD flare, has worsening dyspnea. The nurse asks you what you would like to do. So you check your sign out, and this is is what your sign out looks like in slightly different format. And you're looking through this and you're like, oh my goodness, look at all the reasons she could have dyspnea. She came in with CAP and COPD. She has a history of coronary disease and heart failure. She has a history of DVT. She's on IV antibiotics, getting IV fluids and things she might be allergic to. And she had a subclavian line placed and could have a pneumothorax. So there's just like, so again, just quick differential, literally just from your sign out sheet. Could be a lot of different things. Okay, so what would you like to do next? Do you want to give her some Lasix? Do you want to order a CT angiogram? Do you want to go see her? Do you want to stop her IV fluids? Do you want to activate the cath lab? And I wonder if I can. Cool. Good. See her. Good. Everyone wants to go see her, and that's exactly the right answer. So, but when called to see a person, there are some key first steps as you're going to see her. So on the phone, ask for the vital signs, of course, oxygen saturation. What's their mental status? How much distress do they actually have or do they appear in? And ask a little background, did something just happen? And then think about, prior to your arrival, do you want the nurse or the therapist to start doing anything? Put them on oxygen, put them on a monitor, start an IV if they don't have one, give some albuterol while you're getting there. Do you want them to obtain some data, chest x-ray, ECG, ABG, based on what you think might be going on, so that you have some of that data available when you get there? But you have to go see patients with new or worsening shortness of breath. Okay, so here's the exam. She's in moderate respiratory distress. She's afebrile. Her heart rate's 108. Blood pressure is 128/67. Respiratory rate's 24. Her SAT's 91% on 4 liters. No JVD. She's got some right basilar crackles, an occasional soft wheeze, but she's actually moving good air. She has bilateral pretibial edema, 1+ on the right, trace on the left. What would you order next? And while you're thinking about that, because many of you probably want an X-ray, I hope. But one of my best friends is a radiologist, and he hates it when we just order the chest X-ray as FU. He takes it very personally, and not sure why. And then, and then what he hates even more is when we write FU SOB. So don't do that. Okay, in joking aside, the chest X-ray shows a new shows a right lower lobe opacity that's unchanged from admission. And there's no evidence of worsening heart failure, no evidence of a pneumothorax from that central line. Blood gas 748, 34, 62 on 4 liters nasal cannula. And her baseline on 2 liters nasal cannula was 739, 43, 78. So she's more hypoxemic on a little more oxygen, and she has more of a respiratory alkalosis that she didn't have before. Does everybody see that? An ECG, no ST segment changes, no ischemic changes, no changes from baseline. All right, what next? Good, Kim. She does seem at high risk. CTPE, agree. So yeah, I think you guys are on the right track, actually. And but while you're doing that, while you're thinking about what to do next, I want to talk about a framework for you to assess patients with dyspnea. And these are my 3 pillars for caring for someone with dyspnea. The first thing you want to do is get a safety net in place. Anyone who's really dyspneic, you want to make sure that they're on oxygen, that they have IV access, and that they're on cardiac and other monitors, pulse oximetry and stuff. So think about that first. Get your safety net in place. Then assess their vital signs, because that will help you with your differential: pulse, blood pressure, respiratory rate, fat, temperature, mental status. Mental status is hugely important when assessing someone with dyspnea. And then you want to do your dyspnea survey that I like to abbreviate ABCDE. And that dyspnea survey, let me just, A is for airway. Is there any concern for a partially obstructed upper airway? Breathing, B is breathing, which is the lung. You know, an asthma flare, COPD, pleural effusion, pneumonia, pneumothorax, you get that. So airway, breathing, circulation, which includes the heart, but also includes anemia, pulmonary embolism, shock. So airway, breathing, circulation. D is the hard one in my little mnemonic. It's deficits, it's neuro and muscular deficits. And you will see patients, if you haven't already, who have neuromuscular weakness for various reasons, and who present with dyspnea. And then E is electrolytes and other disorders, acidosis, sepsis, severe electrolyte abnormalities that can actually then lead to muscle weakness and therefore shortness of breath. Okay, good. So you're thinking about those things as you're trying to think about what's the next step for this person. And she has, these are some of the things, they're sort of based on our assessment and the history. We're worried mostly about lung things and then about circulation things, but she's moving good air. It didn't sound much like COPD. There's no evidence that her pneumonia is progressing on chest x-ray. The pneumothorax wasn't there on chest x-ray. Heart failure, she had a little bit of peripheral edema. It was asymmetric, but a little bit of peripheral edema. But her chest x-ray didn't show a lot of pulmonary edema. And the ECG didn't show ischemia. So now, as people suggested on this list, we're sort of worried about pulmonary embolism. Whoops, I'm not sure why that's happening. So if that's what you're worried about, what do you want to order next? Do you order a BNP? Do you order a D-dimer? Do you order a CT pulmonary angiogram, a VQ scan, or an echo? Alex, by the way, I like your interpretation of the blood gas. Bedside echo, absolutely. What's her creatinine? Oh, I think it was normal. I think I showed you it was normal. Oh, Jed wants to know about Wells. What do we know about that? So let's talk about that. Jed, how'd you know I was going there? So I think it's really helpful to use one of the clinical prediction models for pulmonary embolism. There are multiple out there. If you have them on your phone, there's several. It's hard for me to know which one might be best, but one of them is the Wells model, where you assign points to clinical signs and symptoms of DVT, alternate diagnosis less than PE, heart rate greater than 100, immobilization, previous PE, hemoptysis, malignancy. And then you get this probability score. And she has asymmetric edema in her legs. This one always, I struggle with this. This is what the model's supposed to tell us. And so this is like a very subjective part. I think this is one of the Achilles heels of this particular model, but maybe she meets that criteria. Her heart rate was over 100. It was, she has been at bed rest for the last 4 or 5 days since she's been in the hospital, and she has a history of a previous DVT. And so her Wells score is 7.5, which puts her in the high risk category. If you use the revised Geneva score, which is another one of the models that are out there, that take away that that subjective thing of, you know, could it be anything else besides PE? So she actually meets these criteria on the Geneva score, and therefore has a Geneva score of 13, which also puts her into the high risk category. So whichever model you use, it puts her into the high risk category. D-dimers are really not very helpful, except when your clinical suspicion is low. If you have a low pretest probability, a low risk, and your D-dimer is negative, then there's good evidence that you don't need to do more testing. On the other hand, if further tests are planned anyway, you don't need to do the D-dimer, and a positive result is not diagnostic. So a negative result with a negative pretest probability is very helpful. But also the odds of having a negative D-dimer in a person who's been in the hospital is pretty unreliable. So D-dimers are not great. Why is the clinical scoring so necessary? This is data from the PIOPED-2 study, which was done quite a while ago now, but which most people don't remember anymore. And what you see on the x-axis is the Wells clinical clinical probability score, low, moderate, and high. And then what you see are true positives on the y-axis, and on the z-axis, I guess, whether the CTA was negative or positive. And what's really remarkable is that in people with a high pretest probability and a negative CT angiogram, 39% of them still had PE. The gold standard on this, by the way, was invasive pulmonary angiography, which we really don't do anymore. But if you have a high pretest probability, obviously, you know, it's the true positive rate is 99%, but the false negative rate is 39%. And then similarly, if you have a low pretest probability, but the CTA is read out as positive, there's a 38% chance that that's a true positive, that there's a high likelihood that that's a false positive. So that's why it's really important to use the clinical scoring when assessing people for pulmonary embolism. But because she was a high risk person, here's her CT angiogram. And of course, you guys see the big PE on the right and PE on the left. And so she, as you guys suspected, the reason for her worsening shortness of breath was not worsening pneumonia or worsening COPD, but actually was a new pulmonary embolism. Cool. So in summary, diagnostic strategy, determine your pretest probability, Wells, Geneva, PISA, PERC, whatever model you use. I personally don't care. And again, these are all available on apps on your phone. Your basic studies, an ECG, a chest x-ray, usually a blood gas. D-dimers not helpful for inpatients. Follow a diagnostic algorithm. There are times when you will do a lower extremity duplex or a VQ scan, or sometimes even an echocardiogram. And then as someone put into the chat box, always ask, if your pretest probability is high and it's safe, should we just start the heparin now? Because it's going to take 3 hours to get the CT angiogram or whatever diagnostic study you're doing. And that's super important, because the data show that the vast, if you go to assess someone who's had a PE and they're still alive, they don't die from the PE they've had. It's rare for that to happen. They die from another embolic event. So getting the heparin started early is super important. Okay. Questions about that, or should we move on to case 2? Cool. All right, I'm gonna move on to case 2. Okay, so you're still the night medicine intern, and the nurse calls you at 3:30 in the morning to report that Mr. William Paller, a 65-year-old man, admitted earlier that day for an anemia of unclear etiology and COPD, has worsening shortness of breath. The nurse asks you what you'd like to do. You check your sign out. Here's your sign out on this guy. Whoops, sorry. And you can see that no known allergies, anemia of unclear etiology, mild COPD flare. His crit was 22% when he came in. He's got fairly advanced COPD. He's on COPD med, sub-Q heparin, and the anemia workup is ongoing. It doesn't appear to be a GI source. And NTD, nothing for you to do. Yeah, of course you get called to see him for shortness of breath. So based on that, your differential might be that his COPD, maybe he's getting worse. Maybe he's developed a pneumonia. Maybe he's aspirated, no history of that yet. Maybe his anemia is getting worse. Maybe he's going into heart failure, has ACS, or maybe he's septic. So what would you do next? Order Lasix, transfuse him, order a Coombs test, activate the cath lab, go see him. You're gonna go see him. Ta-da, yay. So you go to see him, and he's an older, ill-appearing, overweight man. He's alert and oriented. His pulse is 110. His blood pressure's up a bit, 160 over 105. Respiratory rate's 22. Low-grade fever, 38.1. His SAT's 89% on room air. You listen to his lungs. First, he appears in respiratory distress, and he's a little diaphoretic, and he's wheezing. He's got rhonchi, crackles, prolonged exhalation, no JVD, distant heart sounds, no peripheral edema. And how would you care for him now? And as you think about that, which of these would you not order? Everyone's chiming in so far. Spirometry, but why not? Why not measure a peak flow or an FEV1? Oh, I like Luke's point. Yeah, that's kind of borderline, 89%, not out of the realm of where we like to keep someone with COPD. That's a really good point. But bedside spirometry is just, you know, in asthma, we follow peak flows, especially on the outpatient side. But, oh, excuse me. Yes, spirometry is pulmonary function testing. Spirometry is part of pulmonary function testing. Yeah. So, so I agree, that's not going to be helpful. So let's give you the other data. The blood gas, 729, 54, 58. So a bit of a respiratory acidosis with partial metabolic compensations by carbs up a titch and hypoxemia, PO2 of 58. The repeat crit's 21%. I think I said he was 22% on admission. And his chest x-ray has changes consistent with hyperinflation, but no new opacities, no new edema. So a COPD flare is the most likely diagnosis here. And for about 2/3 of you, we've talked about outpatient COPD management. The other third of you, I'll get you during this immersion block. But for acute therapy, we use oxygen, but very judiciously, as we pointed out. We give inhaled short-acting bronchodilators. We give corticosteroids, and the recent trial, 40 milligrams of prednisone or the equivalent for 5 days is usually enough. Sometimes that study was not done. There were not very many ICU patients in that study. So sometimes in the ICU, we do things a little differently. Limited spectrum antibiotics like a macrolide have been shown to be helpful. Diuretics, for those of you who haven't worked with me yet, if you do, you'll hear my mantra that dry lungs are happy lungs. That applies to almost all disease states. So maybe some diuretics in someone even with COPD, if they can tolerate it. Non-invasive ventilation, and then if needed, intubation and mechanical ventilation. So that's going to be our approach to patients with COPD. And as we talked about, bedside spirometry or PFTs, peak flow measurements, not helpful in managing these folks. A blood gas usually is needed. Usually an arterial blood gas is better in someone with a COPD exacerbation, at least for the first assessment. But venous blood gases are also helpful and can be used to then monitor changes in pH and PCO2. You usually do need a chest X-ray and an ECG, and then you have to consider these other things for those folks. And I don't know if some of you have heard about this, but there's evolving literature that suggests that patients who come in with a COPD exacerbation for an unclear reason, like they don't have pneumonia, they haven't been off their meds. So COPD exacerbations of otherwise unknown etiology, if you do a CT pulmonary angiogram on all those folks, about 25 to 30% of them will have PE that is presenting as a COPD exacerbation, not chest pain and shortness of breath. So you have to have a low threshold for considering pulmonary embolism. Those data are amazing to me, but it's been repeated and verified in a couple of different studies. So that really has changed my practice in my assessment of acute COPD exacerbations when I don't have another obvious cause, no change in purulent sputum, any of that stuff. So, all right, cool.
Is that in despite of a scoring system or like a Wells being I guess low, for patients who are coming in with those PEs, like a COPD flare?
Yeah, Mac. That's a great question, and I would have to look at the different studies to be 100% sure. But my understanding of that was that even in patients who had low to moderate Wells scores, there was still an increased risk. It's almost like a COPD exacerbation of unclear etiology should almost be one of the perhaps one of the criteria. So my memory of those studies is that even in people with low to moderate Wells scores, that they still picked up some patients who had PE. It's hard, right? A lot of COPD patients also have some CHF or some, cor pulmonale. They may have some peripheral edema, and they often are not very active. So they often meet lots of the criteria anyway. So, all right, good. And we did talk about oxygen saturation goals, and the big picture about using oxygen in the hospital is that over the years, in almost every single disease state we look at, the less is more. And so these targets are lower now than they were even 5 years ago. And so in most patients who are hypoxemic, targeting 92% or above and not going too high is actually what's mostly recommended now. Patients with severe anemia, there's physiologic reason why you might want to keep their saturation a little bit higher in terms of oxygen delivery. And then COPD patients, as we just talked about, who are at risk for further CO2 retention, we target lower levels of oxygenation in those folks because both over and under oxygenation are bad in these folks. You don't want to leave them too hypoxemic because many of them are older and have coronary disease and neurovascular disease and things of that sort. But keeping their SAT above 88% and not above 92% is what's recommended there, as was already brought out. So cool, fantastic. Okay, case number 3. How are we doing on time? We're doing great. So case number 3 is an 82-year-old guy with a history of dementia. He's admitted from his nursing facility with fever, a decubitus ulcer over his sacrum. He's getting wound care. He's on pip/tazo. He's getting enteral nutrition. And you're called to come see him for shortness of breath. So just think for a second about your differential diagnosis for dyspnea in this gentleman. You know, airway, could he have had a mucus plug? He's an older guy with dementia, maybe he doesn't clear his airways very well. Could he have developed pneumonia? Could he have aspirated? Does he have volume overload? Did he have a PE? Are his respiratory muscles just getting fatigued from working to breathe? Does he have sepsis? Is he actually getting too much nutrition? You know, too much metabolic demand can cause shortness of breath for some people. So on exam, he's somnolent but awake. He's in moderate distress. He is febrile, 38.8. He's tachycardic. He's a little hypotensive, 95/67. His respiratory rate's 38. His SAT's 97% on 4 liters of oxygen. No JVD. There's a few bivascular bronchi, no crackles, no wheezing, and bilateral trace pretibial pitting edema. So what are you guys thinking? Aspiration, yep. Sepsis, good. Aspiration. Awesome. So a little more data. You get a chest x-ray because you're worried about aspiration, low lung volumes, but actually clear and no evidence of atelectasis from mucus plugging. Sinus tach, no ischemic changes, no changes from baseline. Now what next? Yeah, heart failure too, except his chest x-ray didn't show pulmonary edema. ABG, I love it. Okay. So thanks for that, Lauren. So here's his blood gas, 747, 25, 89. Not hypercarbic. He's oxygenating well, but he has a respiratory alkalosis. MAC, his AA difference would be, with that PCO2, it would be a little bit increased, but not dramatically increased. Oh, a lactate level. Check the MAR. What are you thinking about, Michael, with the MAR? Ah, gotcha. Okay, good. Is he getting sedative drugs? Cool. Well, Michelle talked about a lactate level, and you'd at least probably get just a BMP. And here's his BMP, 144, 3.2, 106, 18, 38, 1.7, 168. Yes, anion gap. He's got an anion gap metabolic acidosis. It's 106 plus 18 is 124, 144. He's got a gap of 20. So it's not just a respiratory alkalosis. He also is hiding in there an anion gap metabolic acidosis. And I don't remember his baseline creatinine, but by memory, I think these were a little bit up, but not, you know, not double. But I do remember a little bit of an AKI as well. So given that acid-base status, what do you, and those two disorders, what do you think's going on? Sepsis, Kim. Sepsis, Becca, awesome. Fantastic. That's exactly right. This guy is septic, even though his pH is 747. And sepsis can do all of this. Sorry, going the wrong way. And sepsis can do all of this. This is a classic textbook acid-base disorder in early sepsis, where the cytokines of sepsis both cause not just a compensatory respiratory alkalosis, but a primary respiratory alkalosis. Many of the cytokines will impact central respiratory drive and give you an anion, as well as your anion gap from lactate, usually from lactate, maybe a little bit from early renal insufficiency here. So fantastic. Good. So you guys are solving all these. And I think we have time for this case. This case was really fun, and I don't know if Gabby Berger has signed on yet, but she and I shared this case a couple of years ago now, and so you're on long call and you get paged to the emergency department at 10:58, just before the cutoff, for a 37-year-old, to admit a 37-year-old woman who has several autoimmune disorders. She has lupus. She also has Evans syndrome, which is an autoimmune hemolytic anemia and thrombocytopenia. She's had several recent flares of her autoimmune hemolytic anemia requiring aggressive immunosuppression, including Cytoxan, MMF, Rituxan, steroids. Her baseline crit from her autoimmune hemolytic anemia ranges from 18 to 21%. And she came into the ED with severe progressive dyspnea on exertion, with chest heaviness and lightheadedness. In the ED, her hematocrit's 19%, so not that different from her baseline, and you're called to admit her. So her medications, again, now currently, are MMF and prednisone. She's on dapsone and folate. She's awake and alert. She has slightly increased work or breathing. She's afebrile. She's a little tachycardic. Her blood pressure is normal. Respiratory rate's 20 and a little bit deep. Her SAT is 89 to 91% on variably 2 to 5 liters of oxygen. She has no JVD. Her lungs are clear. She has a systolic ejection murmur, but no gallop. She has no cyanosis or edema. And Mac says, OMG dapsone, where is the co-oximetry? And Mac, can you tell us why you're worried about that?
Yeah, so dapsone is one of the medications that puts people at high risk for developing methemoglobinemia. And I think with somebody who's presenting with this like dyspnea exertion and their SpO2 is staying in like that high 80s, low 90s despite oxygen, that makes me think about that's just like how the dissociation curve sticks
Yeah.
with that. And so I'd really wonder what her methemoglobin level would be.
Cool. Good thinking. Just to fill out that the chest X-ray was clear. Her ECG showed no acute changes other than sinus tach. I said her crit was 19%, and her basic metabolic panel was this, and her blood gas was 73731, 92, despite those low sats. She actually had a PO2 of 92% on 2 liters. And here she has an anion gap of, let's see, 18. So an elevated anion gap. And so this is probably her blood gas represents a compensatory respiratory alkalosis for compensating for an anion gap metabolic acidosis. So what was next was exactly what Mac suggested. Not one of these things, but there's your co-oximetry, Mac, right there. And in fact, she had a methemoglobin level of 19.6%. That's the highest methemoglobin level I personally have seen. That means that 20% of her hemoglobin was methemoglobin and couldn't carry oxygen. And because she was already anemic with a hemoglobin of, let's see, her crit was 19. So, you know, her hemoglobin was probably 6 or 7, 20% of that couldn't carry oxygen. And so her oxygen delivery to her tissues was extraordinarily low. She had a relative new anemia, if you will. That was the cause of her dyspnea. And Caitlin, I will do that. So, so she got methylene blue. The dapsone was discontinued, and she got better over the course of a few days. I think had to get a second dose of methylene blue, if I remember correctly. But gradually everything improved as the dapsone got out of her system, and her methemoglobin was converted back to hemoglobin. Really dramatic case. And so just a reminder to not forget the non-cardiopulmonary causes of dyspnea: metabolic acidosis, sepsis, both absolute and relative anemia, ascites as it pushes up on the diaphragm, neuromuscular disease, and there's a fairly large neuromuscular disease clinic at the U, and so you may see some of those patients on the wards and in the ICU there, and anxiety. So we all think about the cardiopulmonary stuff, but don't forget those. So in summary, we've reviewed some of the mechanisms, bedside evaluation, and emergency care for patients with dyspnea. And I personally think it's helpful if you think about these 3 pillars: get my safety net in place, assess their vital signs to see how urgently you need to respond, and then do your dyspnea survey, A, B, C, D, E. And I think that will really help you figure out, you know, how to assess your patients. And again, here's the differential for A, B, C, D, E for your dyspnea survey. So with that, I will end. Thank you so much. And when you go up to altitude, even just jumping will make you short of breath. Those are residents from a few years ago up near Mount Rainier. So with that, I will close and give you guys a little bit of a break before Gabby and Dan pick up again with code bias. Any last minute questions, thoughts? I hope that was a little bit helpful, a little fun with the cases, but it's really the framework of how to think about these folks that I wanted to try to share with you. You're welcome. Cool. Okay, thank you. Let's take a break. As Javel said, please stay logged in. You can turn off your video and you can mute yourself and take a 10-minute break and then be back and for Gabby and Dan's session. And I will see the rest of you this afternoon for our afternoon sessions. Bye.
Bye, Ken.
Bye.